So
yet.
good morning to all attendees and welcome to this ELF COVID-19 patient conference. My name is Kjell Hansen. I'm the chair of the European Lung Foundation, and I'm extremely excited to have a wonderful panel with us today. So we also have a wonderful audience with us today. So in fact, we have people registered for more than 40 countries around the world. So before we start, I would like to draw your attention to our translation optional tool. It's called Wordly, and you should now be able to see an invitation to start Wordly if you like to use it. Or a link will be posted to you in the chats for you to use. You can choose your own language and be able to read the automated translation alongside the conference material. We hope that it will be useful to you, but we also understand from previous seminars that it's not perfect. But it's an option then to use. For those of you who are new to the European Lung Foundation, it is a patient-led organization with a patient-driven agenda that works in partnership with the European Respiratory Society internationally to bring the public together with healthcare professionals to improve lung health, influence policymakers, and effect global change. We also have the wonderful researchers from the DRAGON project. So DRAGON is the rapid and secure, i.e. enhanced diagnosis, precision medicine, and patient-empowered decision support systems for corona pandemic. And it is a new innovation medicines initiative project. It is pan-European, that is a project that is using artificial intelligence and machine learning to better diagnose COVID-19 and better predict the outcomes of patients. And the ELF COVID-19 Patient Advisory Group has also helped to develop and organize this event in collaboration with the researchers. Now I would like to introduce you to one of the co-hosts of today. It's the ELF Council member, Helen Parks. Welcome, Helen.
Thank you, Kelt, and good morning, everyone. I'm Helen, and I have COVID-19, long COVID. I had COVID-19, back in March 2020, and it's a privilege to be here this morning. I'm part of the COVID-19 Patient Advisory Group. As I've just mentioned, I'm going to tell you a little bit about my experience of COVID. I was hospitalized back in March 2020, and it was a frightening experience. And at that point, everyone believed that COVID would be a short-lived illness and that we would all get back to full strength pretty quickly. Unfortunately, that was not my experience. In a world before vaccines and before we knew very much about COVID, it was a terrifying experience watching the fear and anxiety on the faces of the medics who were trying to support you and help you on a COVID ward. And not long after recovering, I contacted the COVID respiratory consultant who had been looking after me to say that I was really struggling to get back to full strength. And eventually I logged into Twitter and found that I was not alone, that there were many people who were facing similar experiences and similar problems. And it was through that that I became involved with the European Lung Foundation. And it's been eye-opening and exciting and at the front of all of the information. And therefore, it's been great to get information from them to help support people like you and me. My experience is a common one in people around the world. And there are many people with lung conditions who are worried, still worried about COVID-19 and catching COVID. And they should be worried in that no one really knows how long recovery takes. But we're in the really fortunate position that The medics are much more aware of the disease now. Many people are also suffering with long COVID and worrying that they will never get better. And that's why this conference is so important today. Help all of us live with COVID-19. And we're going to hopefully learn a little bit about the latest prevention methods and how COVID and long COVID can be treated. Of course, this conference is an opportunity for you to engage with others in the same position as yourselves. We want this conference to be as interactive as possible. So please get involved. We want you to engage with others and with us. Say hello in the chat box. Tell us where you're joining us from. And please ask questions, because that is what will make this conference come alive. We know that speakers can't answer questions that don't exist, so don't be afraid of asking a question. And I can tell you that no question is a stupid question. We all are keen to hear from you. We want you to get knowledge today, but we want to ensure that you're getting the right information and that we are answering you and supporting you. If you use social media and Twitter, then please do tweet about the event using the hashtag @COVIDconference2022. I'm now going to hand over to my co-chair, Eva, who will introduce today's programme, and I hope you get a lot from today. Good luck.
Thank you very much, and let me introduce myself, Eva Polverino, and I'm here today, let me say, for a double function or a double, as a double version of me. And you will say, what does that mean? It means that I'm here because of two reasons. Well, I'm a pulmonologist and I've been involved in the management of respiratory infections for a very long time. So as one of the scientific people on this board today. But the second reason is that I've been suffering severe COVID. I've been a long COVID patient for quite a long time. So that's the reason I understand I've been invited. And that's the reason I'm particularly glad to be here. Because living this terrifying experience on both sides in a different way, you know, I think gave me some insight of the disease from a different perspective, and I also think changed me a bit in a good manner at the end. So I was sick, as many doctors at the beginning of pandemic, March 2020. I started, you know, hospitalizing a lot of people. And after 2-3 weeks, I started to have fever. I realized I was sick. Luckily, I had been, you know, I decided to isolate myself from the very beginning from the rest of my family. So I was able to avoid, you know, contagious with my husband, you know. But after, you know, trying to keep working while I was sick, as it was not a severe disease, just fever going up and down, you know, fatigue. I have to confess that about 2 months later, I wasn't able to stand. I wasn't able to stay awake. I had to sleep up to 18 hours. You can imagine how difficult it was to keep working with that. So at that point, I decided to ask for some help, right? And it is when I realized something was absolutely wrong with me, particularly with, I had a sleep disorder, apart from a number of other neurological diseases. This was the beginning of a long journey, as many of you. Almost 2 years of sick leave, trying to go back to work, almost impossible. So fatigue, a number of neurological disorders. Luckily, I was able to go back to work in November last year. And I also have to say that I'm finally okay. I don't know exactly the reason of that. I don't think nobody knows at the moment, but I have to say that I'm fully back myself since last July. And you would say, why? Because I had my second COVID. So something happened. I don't know exactly whether it was your immunological reset or simply I had to go back to normality, but now I'm fine. But I've been living my experience with all of you COVID patients. And, you know, I've been trying to manage the situation also on the other side, trying to keep working as a pulmonologist. And that's the reason I'm here today, particularly glad to be there. So it's a very, you know, intense event for me, you can imagine. And I'll try to explain what we're going to do. We will have 3 main sessions. I will be sharing with my co-chair, the 3 of them. We will have, a number of speakers. I want to thank these speakers, not only because of their long expertise. You will see how important it is scientific information they will be able to provide you, but I will also want to thank you because of their willing to engage with patients. That's the reason we are all here on a Saturday morning. I think it's very clear, right? So we will have a number of talks. At the end of each session, we will have some time for questions and answers. So you will find your Q&A box at the bottom of the screen, so we can use that. We will be reading your questions, so we will have a kind of interaction. Again, as Helen was saying, no space for stupid questions. All of the questions are absolutely important. Please come to us, ask your questions. This will help us to understand, to learn as doctors, and this will help everybody to feel more comfortable with this disease, okay? So thank you, the speakers. Thank you to all of you to come here today, okay? And we can pass to, let me tell you something very important, not only scientific talks. Each of the session will also have a video from some patient that will be sharing a specific experience with all of us. Okay, so this will be recorded. Okay, so you can also see this session again, right? And I think I can I can hand over to Kjell. Am I right?
Yes, you are. So thank you so much, both Helen and Eva. So now it's my duty to do a little bit of housekeeping with you before I hand it back to the speakers. So we are running a webinar style event where attendants, they can only see the speakers and chairs and host of the events. So you'll not be able to see your fellow participants. So participants, except from the speakers, are muted, but they're able to participate in the chat and through the question and answer function throughout the entire event. And please make good use of this, because as it has been highlighted, it's what really brings these patient conferences alive. We are recording the events and we are making the talks available on the ELF website and the EIS respiratory channel after the event, so you and others can freely access them and watch them again. The question and answer session is open for your questions, so you can write it on the question and answer board, and we'll try to answer as many as we can and that we have time for during this event. And those not answered, we will try to get answers from the speakers after the event and put these answers on the website along with the questions, of course. So in addition to this, we also have some speakers who are running polls. So that is a question that you have to answer during the session. So we'll get some information about how is the experience of the audience and what are they thinking about. So would you perhaps like to run the first poll so we can see who is attending today? Can I ask the office to? Yes, there it is. So we have the first poll out. So please answer the poll and then we will have some results momentarily. Yes, so we then have an overview over who is attending the event at the moment. We have 1/3 of the participants that have had long COVID, and now it disappeared for me. Perhaps Claire, can you help me out? There it is, yeah. So 1/3 of the attendants have had long COVID. And we have 1/3 that is healthcare professionals attending the events. So we know that it's a very knowledgeable and experienced audience that we have with us today. So thank you for engaging with the poll. And then I will hand the word back to Helen to start the first session.
Thank you, Kjell. So the first session today is living with COVID-19. I'm delighted to introduce our first speaker, Professor Tobias Welte, who is Professor of Pulmonary Medicine and the Director of the Department of Pulmonary and Infectious Diseases at Hanover University School of Medicine in Germany. He's going to be looking at the current situation with COVID-19. I'll now hand over to Tobias. Thank you very much.
We can't see Tobias, so we think he might have lost his connection. So I think we could perhaps move on to start with Georgia's presentation.
Sure. I think we can pass to the second presentation that I will shortly introduce. As I told you before, the idea today is to, having both components, I would say, the scientific part, but also real life experience from patients. So this is the time for Ron and his wife Maxime to show their video, to talk about their experience, particularly about Ron having a lung condition during the pandemic. So let's have a look at this video. Let's share with them the experience.
Sorry, I think it should be Dr. Georgia Hardavella who's next.
It's okay, Helen. We'll play the video first and see if Tobias comes in back in.
Life before COVID, we was quite active.
Yeah, saw a lot of family, did a lot of things together. we were extremely busy people, even with Ron being on oxygen. We were still doing everything to the maximum we could.
Because of IPF, we had to shield. We couldn't see family. We couldn't go out. It was very lonely, wasn't it?
We had it made very clear to us early on in COVID, when it first started, by several people in the medical profession, that if Ron got COVID, he would be lucky to come out of it.
My transplant team said if you did catch COVID, we would have to park you on the list for up to 3 months until you provided a negative PCR result. So that's in the back of your mind. Do you lose that opportunity? So we took the shielding very seriously. Our philosophy was that if we lost a couple of years because of shielding with COVID, I could have that 5 or 6 year life extension. So in our minds, it was worth it, wasn't it?
Psychologically, I have to say that it's been really hard not seeing family. We've had a new grandson born earlier this year in Germany. We've not been able to go over and see him. We've had to wait for them to come over here. We've missed out on Christmases together. And when we don't know how many Christmases Ron may have, that's massive. That's quite a big thing for us to miss out on. Holidays, just being able to make memories, it's really impacted massively on our well-being, and mentally it's been tough. Yeah, it's been tough.
It's been a strange, I mean, from my point of view, when I grandson was born, I said to Maxine, why don't you go see your grandson so you can hold him and, you know, cherish those moments? But she wouldn't go because obviously I'd have to park myself on the transplant list. So I felt I robbed her of that opportunity to see her grandson when he was first born. We have to be doubly careful, and that's COVID and every infection that's going.
I would just like to say we really had to fight to get Ron to have the 4th jab. He's got the 5th one easier than the 4th, but nobody, the doctor, the hospital, nobody would support us in how. They told him to get it and he should have it, but we were just running round and round in circles until he had a bit of an infection. And finally, the GP said, you need to have that jab. But it meant he had to get ill before they'd give him the 4th. We know that obviously people are vaccinated, you know, high percentage are, and we know that we've got to, you know, life has to carry on. But why is it some hospitals wear masks and some hospitals you don't have to wear them? And as we're coming into the winter and they know it's likely to take off to some degree, why is there nothing being said about it? Even if it's just to the clinically vulnerable people, why aren't they being warned or advised? Even at the transplant appointment, they don't say anything. And you have a registrar sitting in there with a mask constantly falling down off her nose. And you're like, this just feels, you just still
right,
feel so vulnerable. This is our lives that we have to consider, and we don't feel we're getting any support.
Okay, thank you very much. So you have seen this is a very hard story, one of the thousands of stories of the last few years. So thank you, Ron and Maxine, to share their story with us. So I think we can go back to Professor Tobias Welde for his presentation. Tobias?
Yeah, thank you, Eva. I'm back. I'm very, very sorry that I have a little bit unstable internet connection. I'm in the south of Bavaria, and as you can see, so Germany, in terms of internet and IT solutions, is not the best country in the world. I want to give you, during the next 10 minutes, a short overview where we are with COVID-19 and what I do expect for the future. And altogether, I think I can give you more optimistic, an optimistic view on what is going on. So no question.
I'm afraid we have lost his audio again, Tobias.
Applications. You do not understand me.
No, because we have lost you for a few seconds. Okay, so
Yeah, that can occur. I talk again, and
yeah,
what I said is we had a high mortality and a high morbidity, and about, so that's my assumption, 5 to 10% of patients with a COVID disease suffer from long COVID. So we will have to live with COVID for a very long time. However, something changed, and what changed, and this is very important, is the income of Omicron a year ago. And you have to understand, Omicron is a totally different variant in comparison to the older variants, to the Wuhan variant, the classical one, Alpha and Delta. Alpha, Delta are in a way twins from the classical variant, but Omicron is only a very far relative. Omicron is a SARS-CoV-2 virus, but it differs in major circumstances. First, it's very transmissible, which means the infection rate is very high. If you meet someone who is positive, your risk to get it is higher than every time before. On the other hand side, it's not so virulent, it's not so pathogenous. The chance to get COVID pneumonia, and COVID pneumonia was this you died for in the past, is very low. And this is because the Omicron variant did not have receptors to invade the lung and cause respiratory failure. Nevertheless, there are risk groups which are still suffering from severe COVID, and I will come back to this later on. What you can see here, this is the death rate in Germany, is the course of the disease. We started in spring 2020, mean age of the patients 40 to 50 years, mortality rate about 2.5%. And then in autumn 2020, COVID reached the elderly population. Mean age raised to 70 years of age and mortality raised to 5%. Then came Alpha, then came Delta, and these had been more transmissible strains, higher infection rates, but mean age comes down and so mortality comes down. Nevertheless, Delta was the most virulent variant we have seen. And then Omicron. And Omicron is not so virulent, and as you can see, even the incidence rates, the number of infected patients is very high. The mortality rate is very low. But be cautious. In countries who did not face the classical variants, the Alpha and Delta variant, and in countries where vaccination, and we will talk about vaccination in the third part of this webinar, where vaccination is not present, mortality is still high, and this is true, for example, for China. We have some new variants, but I will want to make a long story short. None of these new variants is really virulent. And what we see in Europe, for example, is now BQ1 and BF7, but it's not different from the BA5 variant, which is now present for a long time, but I could talk. What you can see here are the German numbers for infection. And what you can see, we had a small autumn wave, but then it started to drop down, and we are still with high incidences, about 180 patients per 100 infections per 100,000 population per week, but it's not as high as it has been in the autumn phases in 2021 and 2022. And these are the English data. In England, higher population immunity, the numbers are by far down. So the incidence at the moment is around 40 per 100,000 per week. Again, Omicron affects special risk groups more than others. And these are transplant patients, patients with autoimmune disease, patients with hematological cancers, leukemia, lymphoma, and elderly patients who are, we call it multimorbid. So if you are a chronic respiratory disease patient, a chronic heart failure patient, a chronic renal failure patient, a liver cirrhosis patient, your risk is high. However, we have treatment options now. And as you can see here, we have a number of drugs, and I will not go into detail, which help to stop the progression to severe disease. These are drugs like molnupiravir or nirmatrelvir, you know it as Paxlovid. And even for the more severely ill patients, we have options by using dexamethasone and some of the drugs coming from rheumatological disease. So what do I expect in the future? COVID-19 will not disappear. SARS-CoV-2 will one of the viruses which are present, as it is with influenza, with other coronaviruses, with rhinovirus. And we have to find a way to live with these kind of virus. Two major messages. If you are a patient at risk, if you suffer from a chronic condition, you should stay with face masks, for example, in some of the conditions. If you are a normal patient, not severely ill, you can live as you want to live. However, we have to communicate, we have to talk what we expect, and this is a very, very important issue, we have to learn how to overcome long COVID. And with this, I give the word back to Eva.
Thank you, Tobias. And I'll leave the floor to Helen, my co-chair, for the following talk to introduce for the interaction.
Thank you, Eva. Thank you, Tobias. Incredibly interesting. Next, I'd like to introduce Dr. Georgia Hardavella, who's a consultant respiratory physician at Soteria Athens Chest Diseases Hospital in Greece. Georgia will discuss COVID-19 and people with lung conditions, just like Ron, who we heard from a few moments ago. Thank you, Georgia.
Hi, thank you very much for the kind invitation. Can I just confirm that you can hear me and you can see the first slide, which is the title of my presentation?
Yes, thank you, Georgia.
Great, thank you for confirming. Before I start, I just need to share with you my very positive feedback about Ron's video. And it is always that patients gives us a better insight of what patients feel and what the actual situation is, because we have all been struggling over the last 3 years as healthcare professionals with the pandemic, which is not over yet. But sometimes being in a rush to sort out clinical issues and sort out clinical services, we don't always have the time to listen to what patients say, which can be really a new element and gives us a lot of new information that can help us improve our services. So this is just my feedback. I'll move on straight into my presentation. I have no conflict of interest to declare for this presentation. The respiratory tract is the first portal of viral infections, including COVID-19 disease. And it all starts up here when we inhale the particles, and in a subset of patients, it seems that the virus infects or injures the lining of the lung. So this is what we call alveolar epithelium. So essentially, it invades these little red circled areas here that I have highlighted. And this is when the symptoms and all the disease journey starts. When I had a thought about how to deliver this presentation, I just tried to focus on what feedback I had received from my patients over the last 3 years. So essentially, in my mind, I summarized that in 2 important clinical questions. So how does my lung condition impact on the clinical outcomes of COVID-19? And how does COVID-19 impact on my chronic lung condition or chronic lung conditions if I've got more than one? So this is just a graph that highlights the percentage of confirmed COVID-19 cases that were hospitalized in the United States. And these patients had another respiratory illness, a chronic lung condition. And you can see right at the beginning of the pandemic, so in March 2020, 77% of inpatients due to COVID-19 had another underlying lung condition. This percentage was still more than 70% a year later. And then in March 2022, 7 months ago, it reduced down to 21%. So the first question, how does my lung condition impact on the clinical outcomes of COVID-19? Essentially is which is the risk of me having a lung condition and developing severe COVID-19 disease. And what does severe COVID-19 disease mean? It means essentially pneumonia and difficulty in breathing, organ failure in several organs, heart problems, a condition that we call acute respiratory distress syndrome, which is essentially a severe lung condition that causes a low amount of oxygen to go through the bloodstream to the organs, blood clots, acute kidney injury, and additional infections due to other viruses or other bacteria. And this is what the current literature states. So essentially, I have listed here the most frequent chronic lung conditions, so asthma, bronchiectasis, sarcoidosis, chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis, other interstitial lung diseases, and lung cancer. And here is the hazard ratio. And in lay language, what essentially these numbers mean is that the closer the number is to 1, the less is the risk for a certain person that has this specific disease to develop severe COVID. So in lay language, if I am to translate these numbers here, essentially what they show is that asthma appears not to be associated with a major increased risk of the severity of COVID-19. Whereas as we move further down into this table, we can see that chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis, and other interstitial lung diseases are associated with a 50% increased risk of severe COVID-19. And lung cancer, which is in the bottom of this list, essentially is associated with a 2-fold increased risk of severe COVID-19. So it seems that as we proceed further down into this table, things can get worse and things can get really serious in terms of a hospital admission and clinical outcome. So going down into a further question as to how my lung condition impacts on the clinical outcomes of COVID-19, what is my risk of having COVID-19 related death in terms of my underlying chronic lung condition? And again, the table has the same logic like the previous one, and you've got the same numbers here. And essentially, if I am to translate them in lay language, it means that asthma, again, like in the previous table, appears not to be associated with a major increased risk of COVID-19 related death. Whereas as we move further down into this table, COPD and interstitial lung disease, they are associated with a 50% increased risk of COVID-19 related death. And similar is the situation with lung cancer as an underlying chronic lung condition, which is associated with a 2-fold increased risk of COVID-19 related death. We all remember these dark times of lockdowns and shielding, and lockdown was a legal requirement in many countries, and it applied to everyone except for essential workers, and everyone had to stay at home according to the legislation at the time. And shielding was a new term, at least for us that are not native English speakers, where people with diseases or medications that were assumed to be on extreme risk for COVID-19, they were asked to stay at home at all times with support provided to achieve these. And support was not always in place. So we know there is a great variation in practice in European countries, and appropriate support was not always in place for these patients. So the question arises, did shielding help in terms of the risk of hospital admission in patients with underlying lung conditions who contracted COVID-19? And you can see here the numbers before and after shielding, and essentially the differences are quite small. So the answer here is a bold no. So shielding did not affect the risk of hospital admission in these patients who contracted COVID-19 and had an underlying lung condition. And a similar question brings us further down to the next table. So did the shielding affect the risk of ICU admission in patients who had a chronic lung condition and contracted COVID-19? And again, in this table, you can see the differences between the numbers in these two columns, the second and the third column. The differences are quite small. So essentially, the answer is no. Shielding did not affect the risk of ICU admission in this group of patients. And did shielding affect the risk of death in patients that had a chronic lung condition and contracted COVID-19? Same story, same answer. No difference, no basic difference between the two columns. So essentially, the answer is no. Shielding did not affect the risk of death in these patients who contracted COVID-19 and had an underlying chronic lung condition. And we all remember the implications in the social life that Ron and Maxim mentioned in the patient experience video. And you can see the implications that it has in all social activities and all the psychological situation of the patients. So it seems that shielding and lockdown that were in place at that point showed that the association between previous respiratory diseases and severe COVID was generally similar before and after shielding and lockdown were introduced, which is quite disappointing, getting to find out all this information a couple of years later. So how does COVID-19 impact on chronic lung conditions? And you will see in the next few slides that there are quite a few common themes there. So when it comes to asthma, the patients faced barriers to accessing healthcare. And during lockdown, we know that almost 40% of patients reported their asthma management was worse. And half of those reported increased inhaler use. And the majority of patients in European countries, they don't have a personalized care plan. So this is standardized in some countries, but remember, there is a great variation in practice. And on these grounds, there are quite a lot of patients that do not have a personal care plan when it comes to asthma exacerbation of their symptoms. So basically, they use their inhalers while they're in stress on how to manage their symptoms. Asthma patients had persisting COVID-19 symptoms, and these were mixed up with asthma symptoms in general. And due to the fact that there were barriers to accessing healthcare, patients were left basically at home being confused as to whether the symptoms were triggered by asthma or by COVID-19 that persisted long after the initial diagnosis. So there was a symptom overlap between these two conditions. And of course, COVID-19 as a diagnosis and a disease impacted on breathlessness and asthma control. So these are two quotes from patients that participated in a survey that was published in the BMJ by a UK group. I was refused to be tested with extreme shortness of breath and chest pain in March. So that refers back in March 2020. Also had upset tummy and burning in my lungs and pain and headaches. Quote, female aged 40-49, I have never had such symptoms with my asthma or with my oxygen levels. 7 months on, that is after the COVID-19 diagnosis, my asthma has still not returned to normal levels and I'm still on very high dose of my combined inhaler. COPD shared chronic obstructive pulmonary disease shared a similar theme, so reduced healthcare access. And only 12% of COPD patients reported regular access to medical visits during lockdown, while up to 60% of respiratory physicians and GPs reported using telemedicine. COPD patients were forced to reduce their activity during the COVID-19 lockdowns, and this decreased ability to perform daily activities impacted and aggravated their mood disorders. So there were concerns that COPD exacerbations caused by COVID-19 may further increase the risk of cardiovascular adverse events. And this is because there were studies that were published and showed that patients with COPD and COVID-19 that had symptoms, they had frequent alterations in resting heart rates compared to COVID-19 negative patients with underlying COPD. These are two quotes from patients that I was seeing in our post-COVID follow-up clinic. So Male 67-year-old based in Athens, Greece. My hospital appointments were cancelled. I felt helpless and depressed. I felt I was in a tunnel with no light. Female patient, 59 years old. I kept calling for an outpatient appointment for a repeat prescription, no joy at all. Following several weeks, the state implemented electronic prescribing, and I could receive inhalers prescriptions in a text message. For the first time in this COVID-19 madness, I felt something good happened. Interstitial lung diseases, still here we've got a common theme with barriers in healthcare access. There was a shift towards virtual consultation, as with all other chronic respiratory diseases. There were vast cancellations of pulmonary lung function tests due to the risk of transmission, acute exacerbations of the disease after COVID-19 infection, and patients' limited access to healthcare facilities kind of created a vicious circle. Potential fibrotic effect of COVID-19 in an environment that is already fibrotic. So this has major impact on underlying ILD. So imagine you're a patient, you have ILD, and it's exactly based on what Ron described in the film earlier. Imagine if you contract COVID-19 and you have post-COVID fibrosis on a lung that is already fibrotic. Deterioration of pre-existing respiratory failure, and transplant programs across all Europe were significantly affected. Cystic fibrosis, well, this is a very nice table that was published in a review earlier this year. So essentially it summarizes all the impact on cystic fibrosis patients in relation to the COVID-19 pandemic. And essentially, you will see here that transplantation was impacted. There was reduced access to clinical trials. Everyone had to shift to telehealth, really. And of course, the long-term effects of COVID-19 on the CF population remain unknown and need to be reported later on. Lung cancer, which is my special area of interest, this has been particularly compromised in all countries, including Greece. So there was a decreased number of consultations. Patients on a diagnostic or treatment pathway for lung cancer, they feared of contracting the disease. There were hospital cancellations. We had to direct the direction of travel in terms of delivering healthcare. There were significant delays in diagnosis. There was also the fear of contracting the disease there as well, and the fear of patients, of lung cancer patients, of not being admitted to the ICU if necessary. And this was expressed by a lot of my patients that are located in Athens, where we had at the beginning of the pandemic a significant shortage of ICU beds. 1/3% of patients had significant delay in their appointment, in comparison with only 5% before the pandemic. 20% of the delayed patients had advanced disease, and you can imagine the implications of that. We suspended surgery, chemo, immunotherapy, and this led to disease progression and increased mortality. And disease progression in almost 11% of lung cancer patients admitted to the hospital. It was noted due to discontinuation of radiotherapy. And of course, we had disease progression in 26% of lung cancer patients admitted to the hospital due to the fact that we had to stop chemotherapy or immunotherapy. So to summarize, chronic lung conditions impact on COVID-19 outcomes, with asthma appearing not to be associated with a major increased risk for the severity of COVID-19. COPD and interstitial lung disease are associated with a 50% increased risk of severe COVID-19. Lung cancer is associated with a twofold increased risk of severe COVID-19. COVID-19 impacts on patients with chronic lung conditions. There are common themes. There was reduced access to health care facilities. There was restricted access to clinical trials. All these have improved over the last year or so. There have been significant delays in diagnosis and treatment. There were exacerbations of chronic lung conditions driven by COVID-19, and there was poor disease control overall in chronic lung conditions. Thank you for your attention.
Thank you very much, Georgia. I really enjoyed your presentation. I'm pretty sure everybody did. Particularly, it was extremely clear, and it is so important when we have patients in the audience with us, because I think it is very complicated to make it simple when we are used to, use difficult words, technical language, numbers, percentages. So what does that mean? It's very, very hard to understand if you are not an expert, if you're not used to work with those. So thank you very much. And I think we can open the Q&A session. The chat is incredibly active, but I need to ask people in the audience to use the Q&A question. So for the Q&A session, I want to introduce a colleague from the Azienda Ospedaliera Universitaria Policlinico in Italy, Dr. Paola Pierucci, sorry. She will join our session, and you have also already seen her in the Q&A session. She will help us and the speakers to answer your questions. Paola, good morning.
Good morning, Eva. Thank you for the introduction. I'm very happy to be here, and I'm very happy to be able to answer to all the questions that all the participants will ask today.
So we have received some questions even before the beginning of this session. So while we give some time to people to write their questions about this session, I would like to also add a question that we've received yesterday, okay? So are patients with a history of severe pulmonary embolism with some residual vascular damage or restrictive impairment are a more increased risk of severe disease, severe COVID disease, or severe effects of COVID? So can I ask Georgia to give her thoughts about this question?
Thank you, Eva. Well, this is a very interesting question. And I can't imagine that as clinicians, it took us over 2 years to answer it in all this COVID madness. So, and the reason why I'm saying that is because we have gone through several phases with regards to blood clots as a complication of COVID-19. So the answer to the question is not simple. I'm very tempted to say yes, bold and capitalized and underlined, but essentially this has a lot of implications in what we do with this piece of information. So we do know that COVID is related with the formation of blood clots in the legs, in the lung, in the heart, in the brain, so all over the body essentially. And we have addressed that in daily clinical practice by offering to all patients that are admitted to the hospital low molecular weight heparin, which is essentially a special medication that is injected to COVID-19 patients that are admitted to the hospital in a prophylactic way. So it decreases the risk of developing a blood clot during that hospital admission and over the next few days after they're discharged. So in patients that had a big episode of pulmonary embolism, so a blood clot in the lungs, XYZ amount of time before the COVID-19, and they're not on treatment because of the fact that they have completed their treatment or whatsoever, these kind of patients, we know that they have a more increased risk of sustaining another blood clot during their hospital admission. The hot question is, what do we do with this piece of information? And it's a very difficult thing to answer, and there is a lot of variation in practice. So essentially, there are two schools at the moment. We either give to these patients prophylactic low molecular weight heparin, so this little magical injection that decreases the risk of developing another blood clot in the future during the hospital admission, that is, or if the patients have increased oxygen needs up from a particular threshold that we agree amongst us in the department, then we give to these patients a treatment dose. So we treat them as if they have pulmonary embolism, a blood clot. But this is not without risk because it might cause a complication, which is bleeding. And to go a bit further down, there is no way to protect yourself as a patient in the community once you know that you have this past medical history of blood clot in your lungs, which was an unpleasant experience, and you get a positive test for COVID-19. And this is where the anxiety starts. So we advise all these patients, first and most important thing of all, contact their GP. and then they will get guidance on what to do, because each particular situation is different. I hope I haven't answered too much or too less, and I haven't taken up much of your time.
I think you answered very well.
I want to add some words. I agree with Georgia. It's a very individual decision what to do, but all over you can say patients with a history of pulmonary embolism or thrombosis are not more at risk for severe
Tobias, we have lost the audio.
course of COVID-19 in general. So patients with this history are not more at risk for a severe course of the disease.
So it's a very good, thank you, Tobias. I think it's a very positive feedback, because everybody was really concerned about this risk. But I think it's also another point that could raise some concern is about, I mean, if you have a patient hospitalized, you can easily manage the risk of, coagulation disorders by using heparin, right? A specific prophylaxis. What happens with mild COVID that suffer long COVID disorders and potential neurological problems? Is there anybody has an answer about that? Is there any vascular disorder that might be related to long COVID manifestations, in your opinion?
To be honest, long COVID is a multifactorial event, and this may be epithelial, endothelial, so related to the circulation. It may be related to the immune system. Antibody production may play a role. It may be related to the neuromuscular system, and these are not, in my mind, these are not all the same kind of diseases, and in future it needs better diagnosis to find individual treatment. So I'm convinced there's no general solution, the one drug we need for long COVID, but we are just in the starting phase of understanding it better.
I think your answer is particularly important because of it's partially answering a couple of questions that are in the chat. Maya is asking, I mean, about not big, blood clots, but particularly about microclots. That could be a concern. But I think, again, as we said before, prophylaxis should be able to, although microclots are more difficult to be detected. The prophylactic therapy should be able to prevent from big and small ones. And as you were saying, the lack of evidence for increased risk in these patients should somehow leave you more, with the idea that is not particularly at risk. And also about, long COVID. So, yes.
If I may ask also, we carried on a study we basically looked at all the patients that have been admitted with severe respiratory failure in our unit in the COVID unit in Bari. And for study purpose only, we decided to follow them up with a full echocardiogram and an angio CT scan, just to understand, because we knew during the first and the second waves of COVID that there was a very high, we started to understand that there was a very high probability that these patients were going to have a high level of inflammatory process in their vascular systems, and therefore we decided to look specifically at with the help of the cardiovascular department in here. And we actually found that a few patients that were not having any pulmonary emboli during the first admission developed a pulmonary emboli in the follow-up CT scan and echocardiograms. So therefore, there is, I completely agree with you, there is a chronic inflammatory state that persists in our patients. The problem is that we don't know the phenotype of the patients who are going to develop these pulmonary emboli. And at the same time, we don't have a common shared protocol that is used. For example, some of our patients have been on low fraction heparin, as Georgia said, but some of them were on the new oral anticoagulant treatments. And I know there have been a lot of countries that have shared these treatment. In some countries, respiratory physicians started straight away the new anticoagulant oral treatment. Others decided to stay on the low fraction heparin on either a prophylactic or a treatment dose. So I agree with you that there is a lot of variability, and unfortunately, we don't have a precise answer to give to our patients. I guess this is the main problem.
Yeah.
Maybe before we go into the break, I think what is very, very important to distinguish is patients who have been in the hospital for severe disease, mainly during the alpha and the delta phase, are totally different from what you reported from yourself, Eva, patients with mild disease and long COVID symptoms, because the ones who have been in hospital very often show alterations in lung function, in heart function, in other organ systems, which is a consequence of the intensive care stay. But this is not the case in long COVID. In more than 95% of these mild diseases with long COVID, we do not find anything in any organ system. So it's a totally different kind of disease.
Where inflammation and altered immune response play surely a major role, or
but not in everybody. Also not in everybody. Yeah. So what we need is research.
Okay, I think Helen.
There are a lot of questions related to the type of exercise that can be done after COVID. A few of them were actually asked in the chat, I guess, and but also now it's in the Q&A. And the type of exercise they're asking about, high intensity or low intensity and endurance type of exercise, which I think is very interesting. I guess if I may start to answer, and then I will leave to all the other panelists. Basically, I guess there's a big distinction that needs to be done, whether or not you did have a previous respiratory condition, and whether or not, of course, you developed long COVID. Because if you have had a previous underlying respiratory condition and then developed on top of that the long COVID syndrome, unless you were very active, and depending on your respiratory symptoms, actually, I guess the first step should be to get access to a formal consultation by a respiratory physician first. Ask for specific questions. High intensity, it can be very dangerous, especially if you start from a very low saturation from baseline. Some of you, for example, here, I cannot remember the name of the patient, but there were like a baseline of 90 to 92% as a baseline oxygen saturation, which is quite low to start having high intensity type of exercise. So what I would recommend, first of all, to get answer from a respiratory physician, and then to get a full respiratory assessment, which basically consists in an spirometry, a walking test, 6-minute walking test, because during the 6-minute walking test, even if it's for just 6 minutes, you can clearly understand whether or not you have a deep desaturation, so a deep drop in your SATs from the beginning, from the start, and therefore you can understand whether or not you can therefore start doing exercise, and that is very important.
Paula, I'm just going to interrupt you there Sorry,
Sure.
thank you for that. I think we're going to address some of the issues that have been raised in the Q&A when we come to long COVID. And I think at that point, we probably will call on you again if you're happy to answer some questions at that stage. We're about to go into a short break and we're running slightly behind schedule. So can I ask that we limit our break to around 5 minutes, and we hope to see you back again very shortly. Thank you.